Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I'm excited to introduce today's guest, Chad Mulvany, Healthcare Consulting Director at Forvis Mazars and the host of the Achieving Health podcast. So excited to talk about all of those things in just a minute. But before we do that, as friends of Hillsdale Hospital, as Forvis Mazars certainly is, it is very, very exciting whenever we can get one of their leading experts on our podcast to share insights on what's happening in the healthcare industry in many different sectors of the healthcare industry. We'll talk about that in a minute. But Chad, first, before we begin to talk about all these heavy things that are impacting healthcare today, can you tell our listeners a little bit about your background, your role at Forvis Mazars, and how long you've been there, ultimately what brought you there, and why'd you choose that field?
Well, JJ, first, thank you for having me on. It's an honor. And also want to thank you for hosting this podcast. I know you guys started this in a response to COVID to help bring together sort of best practices to help rural hospitals navigate this. But I really appreciate the fact that you've expanded this to a broader conversation about all the issues in rural healthcare today and solutions to hopefully overcome that. I think it's an important conversation and more people need to be tuned into this. In terms of my background, it's like a lot of career paths, it's been long and winding. I came to Forvis Mazars in August of 2024 from the California Hospital Association and really had the opportunity to work with a bunch of people that I'd known going all the way back to my days at the Healthcare Financial Management Association that I'd respected. Have always been a big fan of Forvis Mazars' work and really just have enjoyed interacting with the people. And an opportunity came, as I mentioned, to help them with thought leadership and also help educate clients as to what's going on in DC, leveraging my background, having spent 20 years doing health policy work for first the Healthcare Financial Management Association and then the California Hospital Association, and also taking advantage of some of the earlier stops in my career where I was either working for health systems in their reimbursement and finance shop or in consulting, filing cost reports, or helping organizations set up accountable care organizations and also participate in the various CMMI bundle payment models. So it just seemed to be a nice confluence of one, people I enjoy, two, things I had in my background, and three, things that I enjoy doing.
Wow, when do you have time to sleep? My goodness, this is a pretty incredible background. I did not realize your work with California State Association. I work with Michigan Hospital, and it's certainly rewarding when you work with or for an association at the state level, when you're advocating at the national level for all your respective hospitals. So you obviously come to this podcast with a host of information that you have received over the years and the diverse work you've done. And I want to tap into that in just one moment. But before we do that, you're also a fellow host of a podcast. And, we have here at Hillsdale been very active in the national scene recently with advocating for rural health specifically. That's what our goal is. But I want to ask you a question as a fellow podcaster. What led you to this decision of creating your own podcast? And what do you contribute to the successes of that? And how's it going?
Well, the flip answer as to how I became a podcast host is I've always been told I've got a face for radio.
Oh, yes.
But
Love that
bump. Yeah, no, in all seriousness, I had been a frequent guest when I was at HFMA on their podcast, providing DC updates, helping HFMA's members understand a little bit of the complexities about what was going on in DC beyond kind of the trade press headlines. And when I came to Forvis Mazars, I think one of the things that the team that brought me in was interested in is sort of reprising that because, as you know, DC can be a complicated place. There may be sometimes a little bit more to the story, and sometimes it helps to have someone who has some experience in DC think about what it means for different types of healthcare providers. And so that's really the goal of the podcast is share the headline, share what we think the implications are, and share how we think where we can organizations should respond. And obviously, given how complex this is, it's hard to get into details because what it may look like for a rural hospital may look very different from an urban academic medical center. But that's the high level goal.
So at Achieving Health, the name of your podcast, have you been able to really come around some themes? Is it just a general discussions on all the topics surrounding healthcare? And just to give our listeners an understanding of, do they need to go over to Apple and download your podcast? What are they going to learn?
So it's a great question, and I like the way we have segmented the podcast up. Every other week, we will drop a DC-focused episode where it's me running through, call it the top 5 to 7 news items from the last 2 weeks that I think we could apply some context to and create value for the audience. Mm-hmm. And then every third week, we'll drop a podcast that's an interview with either one of our clients or one of our subject matter experts, someone like yourself, to help the audience understand how their peers, how executives and other organizations that may look like them are trying to tackle some of the many challenges that we're all facing today. And, like to focus a little bit on kind of how individuals came to the industry, what's their why, how they're thinking about the different issues they're facing, and then also ask them to share leadership advice as they think about grooming the next generation of leaders that are coming up.
Yeah. That's incredible. And I've had an opportunity to listen and look forward to in the very near future being a guest of yours. But before we exchange those great pleasantries of podcast, it is critically important for us to understand today, more than any time in our industry, we need leaders and experts who can weigh in on what challenges that we're facing specific to rural hospitals. A lot of devastating news has occurred in the past year, ranging from the one big beautiful bill all the way down to at individual state levels, what the state legislatures are doing to what they would say weed out waste, fraud, and abuse, often at the hands that those words that are being used are unfortunately at the hands of legislators who are then cutting funding to hospitals like Hillsdale. And we'll talk about that in just a minute. Health policy is instrumental to how hospitals are equipped to serve their patients and their respective communities. In this episode, Chad will share his perspective on what's going on in health policy and what to expect in the coming year. We'll talk about the federal finances, the future of insurance, and of course, what all this has to do with rural health. So, Chad, we have seen, heard, read, there is a tremendous amount of chaos in federal health policy conversations over the past year. Now, I say year because it's been going on for quite some time, but it seems to have escalated to a point of unbearable depths. When you turn on the television, left going after the right, you don't even see the middle anymore. Everyone is very on edge. You hear words of nomenclature, waste, fraud, abuse. On the other side, you hear children are devastated. And there just seems to be this great divide in our country as it relates to healthcare. And as a policy expert and podcast host yourself, how do you navigate these conversations? And what should healthcare leaders be talking more about today in their respective communities? Yeah,
and JJ, great questions. And you're right. I think we have been, and I think we knew this was coming when we saw the first Trump administration, the Biden administration, the second Trump administration, that we were going to be in kind of a bit of a policy whipsaw where the federal government was going to change its focus on what was important and what it was pushing through health policy channels. And I would agree, the last 12 months have been hectic. I think for leaders as they're having these conversations, I think, one, it's important to share your data and your story, obviously augment those efforts with the resources that your state hospital association, your state associations, and your national hospital associations are providing, because they do good work and they do provide tools to help sort of ease into those conversations and help you structure them. But ultimately, at the end of the day, I think you have to come with your data. I think the other thing, and this is just sort of my personal process, is I spend, and I know not realistic for somebody who's sitting in your role, at least an hour or two a day reading DC trade press, industry trade press, just to make sure that, you don't miss something. And when you think about trying to be one person keeping up with all this, even if it's your full-time job like it's mine, it's a pretty big task relative to the size of the federal government. So the other piece of this is, when you think about in my role, I've got, at this point, I'm very fortunate. I have a network of people that I've either worked with or have known for years that I trust. And we'll trade notes on this stuff at any given point, in a week or in a day. Usually there's another hour's worth of trading texts or calls with people. And so the other thing that I would say, and kind of the analog that I would apply to somebody sitting in your role, is as you're thinking about educating, whether it's your state legislators, your state regulators, or somebody at the national level, your congressman or woman or your senator, make sure you're having conversations with peers, bouncing ideas off of them of what's worked in the conversations that they've had, what didn't work, what types of questions did they get asked. So you're fully prepared to go in and well armed.
I absolutely agree. One of the things that I truly believe a lot of hospital executives are doing, we're so busy dealing with the day-to-day traumas of our respective hospitals that oftentimes, we just can't give everything to every agenda item. And so what I have noticed in my work with the MHA is what a state association can do. And I know that's not part of what I wanted to talk about today with you, but given your background with California's health association, what would you say to someone listening today? Should I join my local hospital association?
Not only would I encourage them to join, but be active, right? The folks that are working in state hospital associations are incredibly smart. But in many instances, their background is policy. They may have some experience working in a hospital in either a finance role or an operations role. But your colleagues have the day-to-day, on-the-ground, granular stories of the impacts of what anticipated changes, proposed changes, actual changes, and reg or ledge will mean to both patient access, patient care, quality, finances. And so the ability to share that with your state hospital association so that as they're talking day-to-day with state legislators, state regulators, federal legislators, federal regulators, they're armed with good data, good anecdotes to really tell the story and make sure folks understand that.
That's right. Great plug for any state hospital association. This is obviously a national podcast, so if you're listening today in any state, all states have an association. There's rural health associations, but a state association. We'd strongly encourage you, link up with them because you need their voice. They can bring the collective voice to D.C., to the respective state that you're in, so we would encourage you to do that. Now, let's shift a little bit because I want to talk about all things healthcare finance. And there's a lot going on right now, a lot of challenges around what has occurred under the One Big Beautiful Bill. There's a lot of conversations that are happening at the state level to weed out fraud, waste, and abuse, as they call it, and different programs. And the list goes on and on. But other programs are still at risk, Chad, and I think you'd recognize low volume adjustment. That we benefit from that as a community hospital. Which is a big number for us. There's also 340B. There's a lot of finance issues right now. So between frozen state healthcare funding, clawback projects, H.R. 1, the past year of federal financing has been incredibly negative for hospitals. In fact, my good friend Scott Becker, who's an often guest of this podcast, was on not too long ago talking about the fact that his team did a review and over 800 hospitals are at risk of closing in this country by 2032 when the federal legislation concludes the One Big Beautiful Bill. And so this is very daunting as you look at healthcare finance and the way that we're doing business. Difficult to negotiate with payers. The smaller you are, the more difficult it is, and you know the challenges. So I want to ask you this question. As leaders are listening to this podcast, what should we be looking for in 2026, and how should hospitals themselves be preparing for these reimbursement changes?
So I'm gonna start with 340B, and we got some good news. But before I get to my actual answer, I'm going to circle back to that conversation that we were having about engaging with your state legislators, your federal legislators. And I'm going to use 340B as a poster child example of kind of an opportunity to engage. I don't think most legislators truly understand what the 340B program is, what it does, who it benefits. And so my plug would be, one, to be willing to be transparent and have conversations about how your organization, if you're a covered entity, is using those discounts to support access to care for at-risk populations. And so the example that I would use is if you've got your congressman, your congresswoman on campus when they're at home and you're touring them around, be sure when you walk past that neonatal clinic for uninsured and underinsured mothers that you point out the fact that that clinic, if it's supported by 340B savings, make sure to call
That's
that
right.
out. Same thing if you've got
That's
a substance use disorder program on campus that's probably losing money and it's supported by 340B, tell that story. Every place that you're using those dollars to provide access to services that, frankly, if those dollars weren't there, would go away, talk about it. And I know that's an incredibly uncomfortable place for people to be because you don't want to acknowledge that you might have to shutter a service that's desperately needed by the community. But if it's financially unsustainable, if that program goes away, you got to talk about it. So that's kind of the rehash. I think 340B, I think we may have gotten some good news yesterday, and yesterday's Monday, Jan 12th, related to the 340B model. And so everybody's aware of the main suit that AHA et al. Has filed challenging the HRSA 340B rebate model. Case is based on a challenge to the fact that CMS didn't go through all of the steps necessary from the Administrative Procedures Act. They basically took a bunch of shortcuts the law says you can't take. And so HRSA attorneys on Monday have said that they plan to drop its appeal of an order blocking the 340B rebate pilot and instead direct HRSA to reconsider drug maker rebate plan approvals. So, and this is being reported by Bloomberg Law, also being reported by 340B Report. And so if that is in fact true, HRSA may be going back to the drawing board, or at least the starting line, and requiring drug manufacturers to start the process over so that they, I don't think this is the HRSA taking their ball, going home and giving up. I think it's just them going back to the starting line so they can check all the boxes they need to check to satisfy the APA requirements. And so I think what this means is that we're going to get a temporary reprieve on the rebate model, and maybe hopefully somehow or another that temporary reprieve results in the model going away. I don't quite think that's the case given how adamant the manufacturers have been about this, and the fact that you've had several different courts to say that, look, the rebate model is allowable by statute, so the manufacturers are going to continue to press it. But we may get some more breathing room than we had anticipated. I think that's a huge one.
Yeah, but let's go back 340B. You've been working on 340B probably for over a decade, right?
Yeah, no, I should have listened to my mother's advice to stay away from drugs. Exactly. It is, and it's, to your point, these type of programs. I was talking to one of my colleagues in Michigan here, who I'm, working with to try to get them to see the great value that Forvis brings to their organization. Is that listen, with these changes, he was telling me that 340B, he will shut down 3 service lines. Yeah.
As a result of 340B. We're talking about, for me, it's $700,000. For some hospitals, it's tens of millions of dollars. And so these types of decisions that are made in Washington have far-reaching impact to communities like Hillsdale and other rural communities across our country. And I think that's an important fact to point out, is one might scoff at it and go, oh, it's just the big hospitals. And it's just, no, this has major impact. On all hospitals. No,
JJ, you were spot on. And when I said that I don't think lawmakers understand, there's a lot of misinformation that's being put out there by pharma. But one of the basic things that lawmakers do not understand is it is very likely that the hospital in their community that's a covered entity, if they're in the black, it's likely that they're in the black because of the 340B program.
That's right.
And if they're in the red, that hole gets a lot deeper if you pull that rug out from underneath of them.
That's absolutely correct. So those are a few of the programs. Let's talk a little bit about, as we look at some of the other funding challenges that hospitals have. You talking to your folks about, Medicaid reductions, average commercial rate going away in hospitals. What are you hearing that your hospital executives are doing to combat some of this?
It's going to sound trite, but I think everyone is looking at every option on the table. We have, not that anybody wasn't focusing on operating costs, particularly in light of the pandemic or post-pandemic, but they're now starting to think about, what else can we do to improve efficiencies, looking at revenue cycle, looking at deployment of technologies to automate things. So that's sort of one stream. I think there's a reimbursement angle to this where organizations are really looking closely at where there may be other opportunities to increase allowable reimbursement. I think we're going to talk a little bit later about managed care plans, but some of those contentious negotiations that you're seeing in the trade press are a result of the fact that input prices are going up faster than rates of increase across governmental payers and in some cases commercial payers. So you need to get the contracts adjusted for that cross subsidy. But then also there's a certain degree of we're now preparing for what's coming in 27 and 28. The other piece of this is also, I know organizations are starting to look and think more about their strategic options and who they may align with. I know there are a number of hospitals that are starting to think about, their standalone hospitals in rural communities that, have been independent, proud to be independent. But unfortunately, I think the management team has realized that that may not be the case if and when all of these cuts go into effect. And so they're starting to have conversations with their board now to get them ready so they can start exploring options while the balance sheet is still in reasonably good shape before it degrades.
And that's what I've often shared across the country in boardrooms. Those discussions are going on. And if they're not, they should be.
Yeah.
Because we would not be doing our jobs as executives by not laying out, the facts to our board and the threats and the opportunities that exist. And so let's talk about one more threat as we look at it, the subsidies. Can you give our listeners an update on what's the latest? We're hearing that there could be some bipartisan support, but the president's saying he's not going to sign it. Would you have any updates for us on what's going to happen with the subsidies?
Yeah, so it looks like there has been, at least in the Senate, some bipartisan agreement on what the contours of a deal could look like. And so extension of the enhanced subsidies with income caps and also with some protections around preventing, for lack of a better term, false enrollments. And so that was fairly straightforward, fairly clear, and it looks like it could be a 2-year extension. There may also be language in there that in year 2, because it would be hard to set up now for 26, given that we're already into the year, a way to steer the subsidy dollars to people through HSAs as opposed to going directly to the plan, kind of aligned with what the president has been advocating for. The trip up has been the Hyde Amendment, and it sounds like maybe the negotiators in the Senate may have come to grace on some language that at least amongst the Republicans and Democrats that are currently negotiating might address concerns about the Hyde Amendment. In terms of whether or not the president would veto, I think he's been pretty clear that a straightforward 3-year extension with none of the changes that we just described is a non-starter. Yeah. However, given that he has been a big fan of trying to figure out how to, quote unquote, stop sending money to the plans and start giving money to people. If any deal that has a pathway to that, he might be able to squint and certainly nod at. Of course, I obviously can't speak for what the president will or won't do.
Right. I don't think we want to.
No.
So in terms of health insurance companies, when we look at the payers, that landscape is changing today more than it ever has. We hear certain hospitals are dropping payers. That seems to be happening. We at higher rates than we've experienced before. You have the challenges of plans like in Michigan, Blue Cross Blue Shield of Michigan lost $50 billion, something crazy. You're hearing that across the country. What's our solution there?
I think managed care plans could be an episode unto itself. But given the time limits, I think I'm just going to focus on Medicare Advantage, just because, I find MA plans fascinating because I remember when I was at HFMA, you would hear issues and it was a rock in the shoe, but it wasn't any louder than anything else you heard about MA plans. And then something in 2021, 2022 hit a tipping point where the issues just exploded. And I can't quite figure out whether it was just in certain markets, particularly in rural markets, enrollment hit a volume where it became something folks had to pay attention to or what. But, within the last year, at least 41 systems, to your point earlier, dropped out of MA plans in 25 states. I haven't seen more recent HFMA data, but the data that they issued last year suggested that 16% of CFOs plan to drop within 24 months, and another 45% were considering doing so. Yeah. And the thing about that data that sort of strikes me is, and you know this, our audience knows this, dropping a plan is not something you do lightly, given the impact on patients, the community, and just the wide-ranging impact on the organizations, its employed physicians, its aligned community physicians. So the fact that people are actually doing this and pulling the trigger tells me that we're really at a difficult spot. I think historically organizations have viewed managed care plans in general, but also MA plans specifically, as a revenue cycle or contracting problem. And you I think now we feel like we're stuck in an infinite game of whack-a-mole. We make some changes, we get some improvements, a problem pops up over here. And so what we are suggesting to our clients and what we are seeing others do is maybe take a more integrated approach to their portfolio of MA contracts in order to identify a path forward. And so, think about whether participating with a given plan is aligned with your strategic and financial goals. And then, start to think about, are they aligned with you from a quality perspective? And then as you start to refresh that strategic plan, inventory the existing MA contracts to understand why you're participating with each, how a contract supports or doesn't support the organization's physician alignment strategy, both your employed and community, and the contract's financial performance, whether it supports or distracts from the goals, and move forward from there. And obviously, if you think you can salvage the relationship, obviously take the steps to do so. But if you don't think you can, and you can see a path to making some changes or sort of shortening the bench, if you will, of MA plans that you play with, I do think that's probably a more viable option, because particularly in rural areas, the things that where you guys have a little bit more opportunity is that in theory, the plans have network adequacy requirements that they've got to adhere to. And so if you're the only provider or your physicians are the only providers within a given distance, the plan has a lot more incentive to keep you in network.
And we could spend a whole podcast obviously talking about this. And it seems to be one of our listeners' favorites. So I'm going to challenge you that we can come back to payer issues here in the future if you join us. Obviously, a leading expert like yourself on it. What I want to do, Chad, for the remainder of our time is there's been some national legislation. So as we know, under the bill that Congress basically stripped $1 trillion in funding to the Medicaid programs across the country. And there was a concession of sorts given. They call it a concession. It's called the Rural Health Transformation Fund. And what that was designed to do initially is to provide resources to rural hospitals specifically because they knew that we serve a disproportionate share of Medicaid patients, that when the Medicaid cuts do occur, that rural hospitals would find themselves underwater. And when a community like Hillsdale that has 72% payer mix is Medicaid and Medicare, they knew they had to do something, but the president was very adamant that they're not going to replace those dollars, Medicaid dollars, but that could invest in other areas. So program goes out. They announce this $50 billion. Again, cut $1 trillion, give $50 billion back to be divided by the states. We didn't know if it was going to be equally, find out that it's not. And the state would have to go through an application process. The designation of whoever the governor appointed of that respective state, it could even be the governor's office, would be the point person to lead the application for the state. Move ahead. Here we are. The announcements came out. CMS gave the awards. Every state received something. Michigan itself, just as a point of reference, 43rd on the list of 50. Of the number of states that were funded, we were 7th lowest in the nation, and our state chose to use the Michigan Department of Health and Human Services. Other states used similar organizations, or some even used their governor's office. But that is the long way around to describing what the federal government was intending to do with these funds congressional leaders have stood up and said, listen, rural hospitals are going to be fine. They're getting all this money. Well, I do call a point of clarification on that because that's not the case at all. I led the Michigan Hospital Association as the chair of that committee. We submitted our recommendations that would help hospitals like Hillsdale and other Michigan-based hospitals. Not one of our recommendations was accepted. We're hearing that as becoming commonplace around the nation, that input was not relatively wide received from hospitals that had put their information up to the state level, and that maybe the programs that were approved weren't necessarily programs that were going to impact rural health. We'll talk about that in a future episode, but for this purpose, with your vast experience and with the work that you're doing with other hospitals, having studied this funding program, I'm sure you have, how can states and hospitals be good stewards of this funding? And when it's a much lower dollar amount than the losses that we will anticipate specifically starting in 27, but up through 2032, what's your experience with this fund? What have you heard? What would be your recommendation to hospitals on how to achieve the maximum out of this funding?
JJ, I think everything that you teed up in the intro to this is absolutely correct, and I share your concerns about the inadequacy of funding. I'm guessing your audience is familiar with the Kaiser Family Foundation studies that have shown that over the 10 years that 137 billion is going out of rural areas just in Medicaid cuts. And in theory, we're getting 50 billion back, which, I went to public school and state school all the way through. But last time I checked, 137 billion is a lot more than 50. And then you then you start to layer on all of the issues that you just described about it maybe not going to all of the places where it's needed. I mean, those are real concerns. And unfortunately, that cement has been poured, it's dry, and now we've got to figure out how to play forward from there. I think the other thing that I have concerns about are just the very quick timelines that states have to shovel the money out the door. So the $26 have to be spent by the end of Fed Fiscal 27, and then states have to start reporting metrics back to CMS that will start to impact future allocation decisions. So states are going to be pushed to show results. And the analogy in my head that sort of keeps popping up, and it's not the exactly correct analogy, is what we did with the high-tech dollars. Did we need the high-tech dollars? Absolutely. Did we need to digitize our medical records for quality improvement? Yeah. But the short timelines with which folks had to get EMRs in the ground to A, take advantage of the funding opportunity, and B, avoided the penalties, I think in a lot of cases meant that organizations slammed the EMR on top of their old existing processes, and that was probably suboptimal because you've got this new tool and you might want to rethink workflows, but people didn't have the time. So kind of with that analogy out of the way, I think for organizations now, kind of what do you do next now that CMS has approved funding for states? I think it's one, stay close with your state and your state hospital association to understand what's in the application and what the timelines are. And I think more importantly, get a copy of the application and any related materials the state's making available. Sit down if you're a not-for-profit, look at your community health needs assessment, regardless of what your status is, get your strategic plan out, and look for where there are initiatives in your CHINA and your strategic plan that are aligned with what the state's trying to do. And then go from there, particularly if it's something that you've been working on it through your strategic plan or your CHINA, and start to figure out what metrics you can pull to build the business case for one, how much funding you need to help further these efforts, and two, if you've already shown success driving a metric that the state cares about, be able to tell that story so that given the pressure the state's going to feel to make a difference, to show change, you can position yourself as a partner to the state to help drive that change, to drive that metric, to see the improvement that they want to see so that they can continue getting funded at the levels they were funded in 2026.
Yeah, and so many projects following the respective state guidelines is going to be imperative. CMS has made it very clear that you have to adhere to the program guidelines of your state. So I would encourage our listeners today, if you don't know about this, get a hold of your state association and ask them what you can do to put your name in for consideration of this funding. It was designed for rural. A lot of questions in each of the respective state applications about what is rural. It's defined differently from throughout the country, and each state gave their own definition. It seems widely accepted by CMS that the definitions given by each respective state, but it could be a conglomerate hospital, a big tertiary center that owns a small rural hospital in a rural area. They would qualify for some funding, it looks like, in most of the states. So if you're listening today and you have a rural presence or you're a rural hospital, by all means, please reach out to your state association, have a conversation about how you can get in line for this important funding, and then have conversations with your board, with your leadership team about strategic direction. So, Chad, this has been a phenomenal time of conversation. We could spend hours on these subjects individually, and I do look forward to having you back on our podcast to talk in depth about some of the payer issues. And then I really want to hone in on, all right, what are the effects of some of the legislative changes once they come to fruition? And then maybe talk about, what does the midterms mean? What do we expect to see out of the midterms? Would you be willing to do that for us?
JJ would love the opportunity to come back on to talk with you, to be a resource for your guests. Certainly have enjoyed the conversation. I'm excited to have you on kind of as a home and home. So looking forward to that conversation and our future conversations. Thank you very much.
Yeah, and Chad, we'd love to wrap this up with a new closing segment that we just launched called Rural Health Recommendations. And it's every guest we ask, core questions. And we want a recommendation that you're an expert in your field, spent, so many years in healthcare finance and operations. You have a wealth of information. We just need to tap into that because we have listeners that we know are brand new to their roles. Maybe it's a CEO role, a COO role, chief nursing, whatever it is. And we want to tap into the knowledge of our guests. So we do that through this Rural Health Recommendations. I'm going to ask that you contribute a recommendation that you would give. And it doesn't have to be all specific to rural life, but it can have an implication of it. But what recommendation would you give? Sage advice, a tip to a new leader who's trying to make it today in this very challenging world?
So this is probably reflective of my own personality, but I think rural leaders in particular, you are wearing so many hats, right? And I think, if you haven't, make sure you understand kind of the depth of the talent that you have on your team and be willing to delegate more, to create more bandwidth so that, to the conversation we were having earlier, you can sort of create the time to either spend on longer term thinking, bigger strategic picture issues, or starting to engage with folks at your state hospital association, your state legislators, or your federal regulators or legislators. I think it's, figuring out how to create more bandwidth so that you can focus on bigger picture items as opposed to that constant cycle that we all find ourselves in, fighting fires.
Sage advice. We just need to follow it.
Yeah, easy to say, hard to do.
It is. It really is. Challenging times. But for such a time as this, we've been called, and I firmly believe in that. And if not us, who?
Exactly.
And if not now, when? Well, thanks to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you subscribe to the show so that you never miss a podcast. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.